All right. Whose brain is like broken at this point? This is it's a lot of information from a lot of different places. So my goal is to kind of get us all in a space that we understand what that means and equals what we have to do. Because talking about a lot of this is frustrating and angering, and we've talked about barriers, we've talked about all of the issues that are coming down, and I think what we need to really understand is what does the workforce need to look like in order to fix this? Like how do we actually approach it so that on the other side of this, what we have is an addiction treatment line of service, not an X waiver, right? An X waiver doesn't fix addiction. An X waiver is one small component for one drug for a large scale problem that requires a multidisciplinary approach. So just getting 1,000 physicians X-waivered when only 4 out of 10 of those are actually going to write one prescription for buprenorphine, less than 1 out of 10 of those, meaning less than 10%, are even going to reach the 30, let alone the 100 that they could do a couple of years later, means that that's not going to solve the problem. So what I want to talk through is how do we, in understanding this issue, move forward to building the workforce, and then what does that workforce mean for all of these new drugs that are coming down? Because you can't just build an opioid treatment system, right? Because the opioid, as soon as we get that built, which is going to take about 5 years, then that's not going to be the issue. And then we're going to have to get some other waiver to treat, what started off as kind of the benign JWH compounds, which were K2 and SPICE kind of first version, and now we're moving into the ones that irreversibly bind CB1 and CB2 receptors, which means that once it binds, until the brain involutes the receptor, it actually exerts its effect, and that effect is psychosis. I mean, most of my consults in the hospital when I was doing pediatric consults for psychosis was this. It was JWH, it was K2 and SPICE, and that. So this is big. I do a lot of work in Southern California, and in Southern California right now, methamphetamine is the issue. It's not opioids. But the overdoses from fentanyl are happening when they use methamphetamine, as stated earlier. So we have to know how to build a system that treats addiction. Not opioids, not methamphetamine, not this, but the disease of addiction. And we need to take the workforce that we currently have that has a narrow substance that they treat and widen that out. And so let's talk about what that looks like. All right, so this is Lower Manhattan, right? And I want you to think about this as cardiology, right? So this is cardiology, meaning that if you walk out of any of these buildings, you can turn to the right and you have some version of a cardiological specialist. You have someone who does your LVAD. You have someone who does your heart transplant. You have someone who does your heart cath, someone who manages your congestive heart failure, someone who works on just right-sided heart failure, and someone who works on left-sided heart failure. You have an electrophysiologist. And then around all of those people, what you also have are nurses and social workers and care coordinators that make sure that if we do all of these expensive procedures, that they make it through those next phases, especially for those that we do transplant, or send home with a machine that pumps their heart. I mean, the LVAD, I remember when these first came out and they were ICU and there's 50 people, they were as big as a cabinet, and now it's like on your belt and they walk up and they're like, hi, and what you hear is this Archimedes screw kind of going, that's their heart, and it's there, and if the battery goes, they're done. So this is like really crazy stuff. They have all of this. They have all of those people around them and all the kind of accoutrement of a line of service, all the things that you would need. They have CPT codes, billing capacities. They have billing specialists who can maximize this. They're at the point where they're doing value-based approaches to care, and they're making margin off of these really expensive things, even though they are expensive to set up. So a hospital will take out a loan to put in a cath lab. They will take out a loan to put in an LVAD suite specifically for that. They will buy 50 ultrasound machines so that they can do echocardiography on a regular basis for stress testing and all of the above, right? Is that wrong? No, I mean, this is just how it is. And that's what we expect of healthcare in America. When I work, I still work clinically in the emergency department, and so when patients come in with a chest pain, I have all of those things to do. If I work at a rural, critical access hospital, and I have somebody with chest pain, what do? I call a helicopter to come and pick them up if they're having an STMI, a ST elevation MI, right? A helicopter will fly them somewhere so that within 90 minutes we can actually put a needle in their groin and open it up with a stent. So these are things that we've built these systems, trauma levels of care, the ability, that 30-minute window, the golden hour, we've built it around it. So let's talk about what that looks like, because right now, if this is cardiology, then this is addiction, right? So sadly, this is not really untrue, because what we have now, we gather a whole bunch of people in one location, and sometimes it's for 28 days and then they leave. Sometimes it's they gather in one clinic to only treat their addiction. They show up daily for a while, and then sometimes they get to take some stuff home. But most of the time, they'll pop somewhere for a short amount of time, and then we send them off into the wilderness. Now, sometimes they'll gather together for self-help to try to keep the wolves away. Others will wander off, and they will get eaten by the wolf. But what they all have in common, all of the sheep in this herd, they're all eventually going to get sheared. And that is exactly what happens to our patients. The system is not developed to hold them in there, to coordinate care, to make sure that the transitions occur, that the evidence-based approaches to this are mandated. And if you don't use evidence-based care, you shouldn't get paid. I mean, these are just basic things. We don't pay for non-evidence-based care in other specialties, right? You know, I'm a pain doctor as well, so I do, interventions. So I'll do a epidural injection, but we realize that a standard translaminar loss of resistance epidural injection is placebo, so we don't pay for that anymore. You know, unless you do a transforaminal lateral approach for an identified nerve root compression, it doesn't do anything. I know that it works. I have one at L4, and I had my injection, and I've done my PT, and I feel great. Took 7.5 months, and it super sucked, but it works. And we have all of those things put together for that. But this is that. So this is the system of addiction care, right? This is the system that we have to build, the ecosystem of addiction. It includes all the levels of care. Right now, the billions of dollars coming down from the federal government have been specifically spent mainly on level 1, mainly to get people to prescribe. Primary care is not where we're going to send our patients with decompensated congestive heart failure. They don't want it, and they shouldn't have to deal with it. We have to figure out how we build out the same pathways within cardiology so that patients can get the specialty level of care that they know. Because as a, trained in emergency medicine and then board certified in addiction medicine, I know a lot about toxicology. I can evaluate what comes in. I can look at those analogs. I know what my ELISA can and can't do. I know what I'm missing. I know when I need to send it for an LC mass spec and understand, what that information is, and I can interpret that. I shouldn't expect that to be the primary care doctor's problem to deal with. I shouldn't expect him to come up with the regimen to treat outpatient detoxification in a patient who has an oxycodone, prescription, and, oh, by the way, is also a moderate alcohol use disorder patient, and having to figure out how those two work together in a detoxification or withdrawal event. That's not their job. It is the job of the addiction field and the psychiatry field to come together to build out the line of service in the way that it needs to be in order to deliver that. And it includes all of these pieces. It's not just a prescription. So now I'm going to jump into super math nerdy world. So I was asked a while back by a client to build out what does our workforce have to look like? And how do we know that? So if I was tomorrow to flip a switch and build the workforce in order to do this, what would that look like? So what I had to do is basically start with algebra, which is super fun, right? And start to identify all of these pieces. And as we looked at it, and you don't have to memorize, I'm just showing that there's math behind this. This is like show your work. This is the show your work part. And we've built this into a spreadsheet where we can take the overdose rate, and we can tell you what workforce you need at level 1, level 2, level 3, and level 4. And that's not just doctors. That's primary care, specialty level, OTP, level 2.1, 2.5, and that is nurses and social workers and peers. A lot of that for opioids is regulated based on the number of patients that a doctor can see. So if you're a primary care doc, you can really only see 100 patients on your BUP waiver. So we've used that. If you have an opioid treatment program, most states have a 300 patient per provider limit. And then we also have limits on the number of patients per master's level therapist. in a lot of these places that they can hold for the licensing. So a lot of the numbers that we looked at are limited by licensing. So I'll show you what that looks like as we go. So we know that everybody understand the ASAM levels of care? Everybody get this? All right, so this is really important because as I initially trained in addiction, it wasn't mentioned a lot, but I found that it's the most important aspect of this is getting the patient to the right level of care that we have. So we have to start thinking about what that means. And if we look at the staffing requirements for this, we find that level 0.5, which we call early intervention, should just be in existence in every place that touches a patient. I mean, that's the part that should live in every primary care office and everywhere. You know, so that's like SBIRT, right? Screening, brief intervention, referral to treatment, at least basic screening. Less than 10% of primary care docs even screen. And then we have level 1 primary care, level 1 addiction specialist. I don't want to dwell too much on this. I'm just, again, continuing to show the math so that as we get to what we need, when you see the number, and your head is going to explode, because I did it specifically for North Carolina. And so this is an issue. As we build out all of the pieces around the levels of care, the question is what levels of care do we need the most of? And unfortunately, the ones we need the most of are the ones we have the least of currently. So 70,000 patients in Continuum. So Continuum is the online ASAM criteria evaluation tool, and we've now had 70,000 patients who are vetted by this. That gets dumped into a data repository, and we can identify from that not only ways to change the machine learning and decision rules and things like that to help better match patients, but it lets us know where people are matching, like where they need to go to care. And this has been done in rural, urban, so it's LA, there's Ohio, there are a few other states where this has been done. And when we look at those data, we find that you have about 25% that need to go to just level 1 care, and that's kind of split between specialty level 1 and primary care level 1. And then level 1 opioid treatment program is about 10%, but again, that's limited by access. And then we have level 2, and again, level 2 is this intensive outpatient and partial hospitalization. In LA County, 11.5 million people, how many level 2.5s, which is partial hospitalization, do you think existed in LA? 0. And they didn't know that until we did a survey because we found that there was a huge number of patients that matched to level 2.5 needing partial hospitalization, and they just didn't have it. So they have IOP, intensive outpatient, which is up to 17 hours, but it's a week, but it's not the same. There's a reason there are these different levels of care. And then level 3, which is residential, and remember that's broken into a number of places, that's 20%, and then level 4 is 20%. And those are the polypharmacy patients or homeless patients with other medical comorbidities that really need medical oversight for that withdrawal event management and stabilization. So if we look at what the workforce is, and we again take the 2017 numbers, and these are general kind of rounded numbers for North Carolina. You had 2,500 people that died from overdose in North Carolina. Now, if we cut that in half, so we can't build a system for everybody with the disease because at any given time, people could give one crap that they have that disease, right? They are not going to be motivated to go and get help for that. So you don't build you don't have a perfect spacing for everybody with diabetes. We know that. There's a little bit of a wait to get in because people are going to be in their stage of change a little differently. So we need to build a system that is ready for those that are ready for help as we work through motivational interviewing and screening to get people in. And so that's why I cut that in half down to 1,250, because that's the key number that we're going to utilize. So we're going to use that 1,250, and then we're going to multiply that by 292. And so this is the number that's been found through the CDC to identify per overdose the number of people needing treatment. So for every overdose that you have, there's a certain number of people that need treatment, based on that. And this number goes high or low, and what that looks like is it depends very much on the naloxone that's in the community. So if you flood the community with naloxone, you're going to have less fatal overdoses. Doesn't mean the problem's gone away, right? And then you have less naloxone in some places, so you see an increase in overdose deaths. But it equilibrates. So the 292 is kind of the middle number because it's been everywhere from 172 all the way up to about 375. So it's just kind of the middle number through kind of Bayesian mathematics to get to that. So that means 365,000 people ready for treatment, which luckily kind of matches a lot of the numbers that I saw earlier that were done independently. So the math is starting to be consistent enough to where we can start create predictive analytics. And then we, based on the fractional FTE per level of care for this, so we cut out like who do you need and where do you need it. So if we looked at this, the assumptions that we would need to find for North Carolina is we need 100 primary care doctors working at 100 patients, right? So, which we know is not going to happen, so you probably need 10,000 primary care doctors doing one, I don't know, or a half of one. But, whatever that number is, but, if you had 100 meeting that, then that would suffice for what you need at that level. And then the specialist, which can see as you go here, I'm sorry, which slide am I looking? Oh, let's go back. So if you go here, so a primary care provider is 100 of those, the patients per provider. So I'm sorry, I was skipping ahead to the next one. So if you look at this, you have the level 1 primary care doctor. They can have up to 100 patients. The MSW can kind of treat up to 100 patients in that primary care. We've done all this primary care behavioral health integration at this point. They can kind of manage up to about 100 patients. Not heavy hitter 100 patients, right? But just kind of the mild touch base and movement forward. And then RN case managers, they can handle generally a panel of about 300 patients effectively. And then if we go to the specialist office, the MD can legally take up to 275 patients for buprenorphine. Now, not including naltrexone if they add that on. And then MSW, about 90. That's pushing it, by the way. I mean, I ran a specialty outpatient office that was integrated, and 90 was a beating. They could do it, but not everybody got that high intensity. But as we know, people don't stay at that high intensity of care, right? It's all deep dive, high intensity up front, and it tailors. So once they've been in the system for a while, you have those that have tapered, and then you have those that are new, so it does equal out. And then you can see you need about 200 patients per case manager, which is, again, a beating and unrealistic. But if I took that down to the number that we know, the number I'm going to give you at the end would be untouchable, quite honestly. Opioid treatment program, 300 patients, IOP 30. You can see all the numbers. So these are the numbers that we use to measure the capacity of individual providers at those levels. And then I'm just going to point out a couple of basic numbers on this. Again, the 365, and if we look at, let me see if I can find it right down here, patients, as we break them out, if you look in this column right here, this is the number of patients per level of care. So 91,000 for level 1, 109,000 would meet for level 2 or IOP, partial hospitalization, 55,000 for residential, and 73,000 for level 4. Again, level 4 is a quick hit. It's not a long-term treatment pathway, but they still need access, to get that initial stabilization before they step down. The total workforce required, and I'm going to shift over to the right here, and this is if we minus the existing workforce. So this is what we need to add. So what needed to be added is we needed to add 776 primary care docs, 282 specialists, 310, this is just the MD column, by the way, MD, DO. Now, this could be halved by using NPs, PAs, now that we've expanded X waivers, but we still need to put into a very specific training pathway so that they can have their own specialty training level for this, because you can't just drop someone, with the equivalent of a master's degree into this cauldron of pain. It is really painful. I ran this clinic for only severe patients. I had 2 physician assistants, brilliant, by the way. One I just stole and hired in to help me do this work around the country. And he was the first X-waivered PA in the country, and he's been treating pregnant and parenting women for the last 5 years after I left on his own. So I would trust him with any of my family members. But as we start to kind of look around where we go, this is a lot of people we need. We need like 3,000 docs or PAs or nurse practitioners, 3,000 people just to treat level 4 to be available. And because if you think about if you staff a level 4, one person can't be on call 24/7, and that's 24/7 availability, which means you have to have round-the-clock staffing, which means that you have to have people that can see patients. You can only see so many patients and write so many notes in a day. This is reality. And interestingly, this is still a little less than cardiology. There are 35,000 cardiologists in the country. And then when you add in transplant surgeons and all the people around it, there are about 50,000 MD-DO level providers for direct care for heart stuff, for the pump. Which sometimes when the patient's asleep and you're just working on plumbing, that's a little easier than a patient that is awake and yelling at you. Sometimes a lot. And so this is a lot. So I'm going to get to the meat of this. And I didn't put the slide on here. So we did this Monte Carlo evaluation of what that would mean for cost. And we took the average salaries in North Carolina for each of the providers. It's billions of dollars. I mean, it's like $6 billion per year. Now, most of that $6 billion comes out of billables, right? But the problem is that the actuarial evaluation that insurance companies get, meaning the cost per patient per month, hasn't rolled into the fact, what if we actually had care for these patients? Because the minute we do that, we bankrupt all of the MCOs, the managed care organizations. They recognize this, we recognize this. So it's a transition to get to that. But what does that mean? So let's say we hired all of those people. Now, recognizing on opioids, here's your work day if you have opioids. Only really about 60% of a patient with an opioid use disorder, 60% of their work is kind of medically driven. You know, there are medications, we're looking at infectious disease, we're identifying other side effects of that. There's a lot of doctor time in this one. And about 30% of that is behavioral health. And I'm taking into account mild, moderate, and severe because we're finding for mild, medication-assisted treatment may be beneficial by itself, even without behavioral health, which I still only saw severe patients, so I called kind of BS on that. But for a very mild subset, that may be all they need is that stabilization to get back to work and have family and all of this. And then about 10% case management. So that's an opioid. If you ran an opioid shop, that's what your time looks like. The problem is that means 40% of the doctor's time is still unaccounted for, right? So they're going to have to figure out how to cover that if you're not billing for that 40%. And we've done that by overdoing toxicology studies in the outpatient space to confirm a med that we know that they're on and expected them to be positive for, but yet we need to spend $1,200 to confirm that medicine is in their system, just to make sure. That's not okay. That's billions of dollars that we lost. But look at this. So what about if we added in alcohol treatment to an opioid treatment program? At that point, now we added another 30% for medical. Ooh, we're getting closer to an actual FTE of work for that provider. And then we start to look at, the 30% that we add on the case management. Now we've filled 40% of their time. So this starts to work out when we start to add other addictions into the workforce that we're having. And then when you look at the behavioral health, they're about 70% occupied now. So this is good. So now adding on the treatment for another addiction into a clinic that may have been primarily developed for opioids actually makes business sense because now you're filling out the FTEs that are required to take care of this. And then if you look at marijuana, at this point, that's mostly behavioral and care coordination. Depends if you're an adolescent clinic versus an adult clinic. Number one cause of admission for adolescents is still marijuana, has been for a decade. So this is an issue that we're going to have to deal with. And medical is probably going to have an evolving role in this. For adolescents, N-acetylcysteine seems to be pretty effective. We can't get it paid for because it sits on every shelf as a supplement. So because it's a supplement and it's not something we can really write a prescription for, it's not really getting paid for. But $40 pays for 3 months on Amazon if you order it. We ordered literally buckets of this stuff. We ordered it by the kilogram for our clinic and just gave it out in little Ziplocs to our patients who were on marijuana who we needed to decrease that. So N-acetylcysteine, everybody knows that medication. Mucomist. Yeah, it's what we use for Tylenol, acetaminophen overdose, because it blocks the metabolic pathway that creates the toxin that destroys the liver parenchyma. And so when that happens, It's great. They were using it as control for functional MRI studies they were going to use it as the control drug because they thought it was completely inert neurologically, and what they found is it blocks the release of dopamine from the shell of the nucleus accumbens from the endocannabinoid system. So it's specific to that, and it seems to block it, so it has some really good effect. Plus minus on the adult literature definitely seems to be effective for adolescents. So there is a medical role and probably evolving, but also the endocrinopathies that come along with significant cannabinoid use, whether that's THC-based, and the ones that we haven't identified yet. I mean, cannabidiols and everything now. So we're going to have to wait and see what the endocrinopathies of that one are if used at a high level over time. And then we have methamphetamine. And this is going to be brutal. So marijuana is going to present, opioids was the big mortality problem, right? That's its big issue. That's the thing that drove all of this is the mortality. Marijuana is going to follow that with a massive morbidity problem. It's not going to be necessarily mortality, but when we have people who are lazier, stupider, and more clumsy, those are problematic for society in general, especially if we're dropping an extra 10 points off of IQ. Recognizing that in DC now we're struggling with IQ requirements. So and I say that as the outgoing chair of the Legislative Advocacy Committee. I get to hand that off in 10 days after 4 years of a beating. So when we look at this, what we have to really think about is we need hundreds of doctors, nurse practitioners, PAs, midwives, all of this group of people who can help to work on this problem. We need hundreds of primary care physicians. We need hundreds of master's level therapists and hundreds of RN case managers dedicated to addiction treatment. So this workforce problem is not going to get fixed with educational programs. This workforce problem another webinar is not going to solve that, right? I've given hundreds of webinars, hundreds of talks, tons of topics. I just finished building the pain and addiction curricula for FACEP, so that's all like deep dive neuroscience. I love that because I can just deep dive into my book of neuroscience, which I enjoy. This is the thing that's going to change it, though. Building the system of care around this is what's going to fix this. And until we start really involving hospitals, they have to lean in. If they don't, we're not going to get there because 3/4 of those buildings that you saw in that picture for cardiology live in hospitals, right? And until hospital systems lean in and build this out as a line of service, it's not gonna work. Until we identify that using one drug for one disease on one patient, i.e. methadone clinics, is not the best utilization of specialty knowledge, that we need to expand the capacity within our opioid treatment programs to just be addiction clinics and have methadone as one of the things that they do. Until we identify that we need to turn them into IOPs because they have the whole staff, they're there all day, you extend some time, add a few FTEs, the business model for this doubles their margin. So we have to start thinking about this from a business standpoint, from an MBA lens. How do I build a workforce around what we need to do to deliver this? Amazon built a workforce to deliver all of these things to us on a pretty regular basis because they had a good business case and they thought about it in that way. When you build these things out, then you can start to understand what role your educational platform plays. What role ongoing, quality evaluation plays. I mean, we have to deal with capacity, competency, quality, and payment. All of those things have to be dealt with in order for this, to occur. So we can have another webinar on stigma. It exists, it sucks. It's really in the way of getting things built. There's no question. It's actually discrimination now. It's not even really stigma. We just have too much data for treatment, so it's willful and wanted not applying of evidence-based medicine, which actually in my mind goes past stigma into discrimination. And the really interesting part of this, the states that have expanded Medicaid, and I've worked now in 40 states around the country, about 5 of which have not expanded Medicaid. I don't know if you can build the system unless you do it. In fact, I know you can't. The math doesn't work. No hospital's going to invest in a line of service until they can get 46% of their bottom line, because there's only so much you can write off. I mean, there's a portion of it that gets written off, but what also gets written off is the patient. And when I talked in Kentucky the other day, I said very specifically, people should have the freedom to be well so they can work. Because if you are not well, you cannot work. And if you want people to go get a job, you can't say, I'm going to cut your right leg off and let you bleed out. Go get a job. I mean, and that's what we're doing with addiction and behavioral health, cognitive disorders, and chronic pain that's untreated. So we have to figure out how to get there. And I will just be honest with you, from a business standpoint, you will not fix this problem unless you expand access to health care. You just won't. And I'm not a North Carolinian, and I am, however, a Texan. I was born and raised there, and they have also not expanded Medicaid. And my brother, I had to pay out of pocket for a shoulder issue that he had. He's a tiler, and didn't make enough. He's a tile contractor and didn't make enough money to get it fixed, but then he couldn't work because his shoulder was busted. And so we just had to, as a family, pay for him to get shoulder surgery. But if he didn't have that family, which I'll tell you most people don't, and what I mean by family is the doctor in the family had to pay for, the shoulder surgery. Let's just be honest about that. The older brother turned. So when those things occur, if he didn't have the older brother doctor who understood who to call, how to get it set up, how to talk them down on cash price at a hospital by calling the CFO and saying, "Look, dude, I need this done. I'd like it to cost what I know that it costs you," and do that. And I was able to get it done for $7,000. An entire shoulder reconstruction and all of this stuff. So we know that these things can get done. But who has that? I mean, how many people have the CFO of the hospital in the city that they grew up kind of on their speed dial because they used to go party with them in college? And you have dirt on them. I don't know. I do. But as we start to look at what it is that we're going to do with this, we have to recognize that if you add all of these together, the medical time is about 31% of the need. About 50% is the behavioral health capacity, and that's a whole other ball of wax, right? How many people have master's level therapists who are certified in cognitive behavioral therapy, certified, just a sec, I see it, it's like, I see the hand going, certified in EMDR, certified in dialectical behavioral therapy for those that have, personality disorders, right? So we've talked about addiction, and we didn't talk about, I'm not spending any time talking about the thing that we know is the causative agent for the vast majority of ails in our country right now, which is trauma. That really is the underlying reality of most of this because of the neurobiological changes that take place and set people up for addiction and mental health disorders. But we don't know what happens when those doors close when they do therapy. We don't have good academic detail, and we don't have good oversight. We don't have good training programs. We don't have any consistency around this. Some places do it great. There are some places I've been to that are small, and they do a wonderful job, and I know all these people are brilliant, and they do excellent. Everybody wants to do a good job. We just haven't really built the system to allow that to happen. So what I would have you think about, and what I want to leave you with is, as we have an emergence of all of these new drugs, addiction is the overarching theme. We'll have treatments for specific drugs that we know work. We know contingency management strategies actually do work relatively well for methamphetamine. If by relatively well, I mean 31%, which is, not great for a pretty destructive drug. But at the same time, it works, but we don't pay for contingency management strategies, despite that being the only, pathway. We know that medication is the thing that works. It's standard of care for opioids. We know that medication and behavioral therapeutics are standard of care for addiction. But even within our field, we fight each other. We get emotionally involved in these decisions. So we need to, use our inner Spock, which is our hippocampus, and just utilize the memory and knowledge that we have for what works and build these systems of care in an integrated fashion. But it is a Herculean effort to do so. And I think if we understand that moving forward, we'll get through that initial phase of shock and frustration of, it seems so big. It's not. Each of you work in an office. Build one level of care up or one level of care down. If you work in a hospital, get them to add a little piece of a line of service. Maybe just a nurse practitioner to see patients and do a good evaluation and have a social worker write a good treatment plan and do a co-triage, like a short version of the ASAM criteria, so that when they get discharged that they're going to go to the right level of care. Basic things that we do for every other healthcare disease that we have out there, other than mental health, by the way, because mental health disorders suffer from the same inequities. It's doable, But I think we need to shift now to the mindset piece of the MBA. How do we implement it? How do we set it up? What is the margin? What is the growth rate? What loan do we have to take out to get it done? Because the money that's coming down that was on the slide up here, it's done after H.R. 6, guys. The feds have checked the box of done from a money standpoint. They're not going to be putting billions more dollars out to do this. So if it doesn't get fixed and all you're doing is supplanting treatment and you're not building systems, your overdose rate will skyrocket in 2022 because you will run out of money to treat them with meds. You will run out of money to give naloxone on the streets, and everybody will start dying again. So remember that if you don't set these systems of care up now, the money is gone. It's not going to happen again. So now's the time to do it. We know what we need to do, and now we just have to figure out from a business standpoint in your little square foot of the world, how do you expand your capacity to meet the need? Thanks.